It's great to welcome you all to our MCHRI Seminar Series, our lunch seminar series here. It's awesome to see so many folks in person, encouraging those online to consider coming in person to the next one. There's good food here, and it's a great room downstairs in the bottom of CAM. So we're here to talk about a really important topic, which is about how we increase diverse representation in our studies, particularly related to maternal and child health. And we have two terrific speakers to share some of their thoughts and wisdom here with us, which I will introduce in just a moment. But just want to give a shout out, let's see, make sure, there we go, to our MCHRI Education Committee, which puts a lot of work into helping to design and put together seminar series like this one, and a lot of other work that goes on across the School of Medicine and the university related to our MCHRI goals. And just a shout out to a couple more seminars that are coming up rapidly. Put them on your calendar. One later this week about, let's see, oops, I think that's the wrong title there. So yeah, that's right, about qualitative measures, methods. That's coming up, that's tomorrow. And then there's a grand rounds, a hybrid grand rounds on the 27th next week. That's also really related to an important topic near and dear to the MCHRI around community engaged research. And last but not least, of course, we have our annual symposium coming up on October 19th. So if it's not already on your calendars, or if you have not already RSVP'd, it's a terrific meeting that will feature some phenomenal speakers around climate change, as well as some other topics that I know are really relevant to many folks in this room, like PedsNet, which I see a PedsNet leader here sitting in front of me. Oh, there we go. Oops, we have some feedback coming on.
Sorry.
So let's get started by introducing our speakers. So first we have Dr. Ananta Addala here, who is a pediatric endocrinologist and physician scientist who does a lot of her work addressing disparities in pediatric type 1 diabetes management and outcomes. And she aims to build evidence-based approach to addressing type 1 diabetes disparities by systematically evaluating youth, their family, providers, and more importantly, the system level barriers to optimal diabetes care. She's also been leading efforts to improve justice, equity, diversity, and inclusion in her research at Stanford University through her leadership on the Pediatrics Advancing Anti-Racism Coalition and the co-chair of the TrialNet's Underrepresented Minorities Outcome Committee, both of which will, I think, shape a lot of her comments here today. So thank you, Dr. Addala, for being here. Also joining her is Dr. Maya Berdichesky. Maya provides really critical leadership and support to the Stanford Clinical Translational Science Award, known as the CTSA's new collaborative initiative, the Trial Innovation Network, which consists of over 60 CTSA hubs, including innovation centers providing resources for operations and trial participant recruitment, very relevant to today's topic. So she manages and fosters engagement between not only Stanford's hub and then the TIN. So thank you for being here, Dr. Berdichesky, and really looking forward to both your comments. So I'll turn it over to Dr. Addala. Oh, yes, you do.
Thanks everyone who's here and who's joined virtually. Hopefully you can hear me just fine. So I'm really excited to talk to everyone here about what it means to consider DEI in research specifically. And a lot of the principles are going to be grounding on this tweet that the NIH put out back when they were trying to recruit for COVID vaccine trials, which is clinical trials should be as diverse as people at risk for the disease. And before I go much further, I do want to stop where part of this event is in person. So I do want to do a land acknowledgement of the ancestral lands of Stanford. It belongs to the Ohlone tribe, and this land has been and continues to be of great importance to the Ohlone people. And I do land acknowledgements, particularly for in-person talks, for two reasons. One is it's important to do the acknowledgement, and two, it's one of the most classic ways of how far-reaching systemic inequities are. This land did not used to look like this, certainly didn't have this lovely building not long ago, and really it's a presentation of how pervasive historical inequities still are day to day, which is very relevant to our conversation. And the challenge in really thinking about why clinical research and clinical trials and their equity matters is that in research, we're generally trying to think about the generalizability of findings. That you're doing a study that isn't just applicable to me, Ananta, in my various needs and wants and medical conditions, but that it's applicable to a broader population of people. But as I was just saying, there is some inherent privilege to being an individual, and that's sometimes lost. So to me, the crux, I wouldn't want to climb that mountain, and sometimes it feels like I don't want to climb the mountain of research equity, but I do, and you're going to come with me, is in trying to really balance these two components. Back in what feels like it was only a couple of years ago, but since it was published in 2002, was actually something like 21 years ago, the Institute of Medicine put out this sort of authoritative and definitive review of where the state of inequities are in medicine as a whole. And they proposed this model that says, this is how health outcomes are inequitable. And I've actually adopted it for our conversation here to say, how does that really look with research participation? So we know that there's a difference in research participation for individuals who hold minoritized versus non-minoritized identities, however you define that. And there's a myriad of ways. And that difference, and this is youth because we're here at this MCHRI, but it's also the family and it's the mothers. Part of it is that there's a difference versus a disparities, what the Institute of Medicine says. And they said that the preference of the family or the youth or the mother is not part of that disparity, but the infrastructure of research, including who does research, again, this is adapted, and who the research staff is, that's certainly a place where disparity can be introduced. And then of course, sort of the classic stuff, which is discrimination, bias, and stereotyping. Now, I would posit that true preference is absolutely important. If somebody does not want to be in a clinical trial, you should not make them be in a clinical trial. And there's plenty of historical atrocities where that's a clear learning point. But I think that to say that the preference alone and not realize some of those structural drivers to why somebody is or is not comfortable with research, there is actually an equity and a disparity consideration in there. So what do I mean by that? I'm going to kind of take you through. I really like to think of the world like an onion, Shrek, onions, and pediatrician first, which is that the individual is really nestled within multiple other spheres, and that's called the social ecological model. And I'm going to start all the way at the top, which is the system. And I really want to take a moment because the whole point of my portion of this talk is to really set the stage. Where are all those inequities? Where do they come? And I'll offer some solutions, and then Maya will bring us home with specific solutions here at Stanford. So this is 2018 data on individuals by race, ethnicity who have R01 level funding. So those are individuals who are considered independent researchers by the National Institute of Health and what you can see is that there's a disproportionately overrepresentation of non-Hispanic white individuals. And then next up is Asian at 26%. And then if you look at the remaining here, 2% identify as Black, 0.3% identify as Hispanic. I haven't seen newer numbers come out, so if others know that there are newer numbers, please let us know. Also, for those of you who are online, you're going to see me move a lot because I'm not and the camera is still, but I am not. So hopefully I won't give you motion sickness. But I think that the importance here, though, coming back to the topic at hand, which is when a lot of clinical research, especially the hypothesis generation, comes from clinical interactions, comes from lived experience, and comes from what we're exposed to. It's hard to envision what a hypothetical problem might be. And and this is just one way that diversity is a little bit homogenized within research, when the lived experience is disproportionately representing one racial ethnic group, then the challenge is that there might be blind spots that we're not even aware of. And how that shows up is in the study questions being asked. For example, only with the increasing diversity of the research staff and researchers have we started to consider some of the social determinants of health, what it means to have perceived discrimination and the implication of that on health outcomes. Really importantly, it comes to how we do our techniques and how we the logistics of how we do research. If you don't interact often with individuals who don't speak any language other than English, then you might think, oh, an English consent, that's good. I'm already covered for everybody. But in fact, that's not going to be the case. And then I think what happens also is, particularly in academia, we tend to really take all of our study results and only send them to academic journals where the community, policymakers and other individuals don't really have access to really meaningful data that can impact the lives of many individuals. So that's sort of why there's inequities. And as it was said in my introduction, and as those of you who know me, I focus the majority of my work on diabetes technology. So I'm going to use that as an archetype for why equitable research is really something you should care about, even if you don't do any research. And so I'm going to highlight here. So diabetes technology, I don't want to make anyone here an endocrinologist if they don't already want to be one. But the long and short of it is that there are sensors that you can wear on your body, and there's pumps that you can wear on your body. And they help improve your diabetes outcomes, and they help your life be just better. And for anyone who wants to know more, come find me afterwards. I'll talk your ear off about it. But coming to the point at hand, this was a commentary that was published in our sort of sentinel journal in diabetes that says, when you look at the racial ethnic diversity of these randomized control trials, the gold standard of clinical trials that got all of the FDA approval for the various diabetes technology devices, you can see that there is an overrepresentation by 84.5% of individuals who are non-Hispanic white. And many people come back to me and say, well, Ananta, I'm all about diabetes clinical trial equity, but type 1 diabetes is predominantly a disease of non-Hispanic white individuals, right? So isn't that okay? And the thing is, it's actually still an overrepresentation. So there's 2 points, and this comes back to the narratives that have long existed. So part of it is around 70% of individuals with type 1 diabetes are non-Hispanic white, so it is a majority. But the other component of this is that the racial ethnic demographic of the people who are getting type 1 diabetes is changing. And so to kind of ground on older data is not particularly helpful. There's an overrepresentation, and by there being an overrepresentation, there's an underrepresentation of the remaining racial ethnic groups. And I told you there's many ways that people can be marginalized. And this is just table 1. And this is a fun/sobering activity I like to do sometimes, where when somebody's really excited about a clinical trial and they share with me that paper, I hang out with the table 1 for a little while. And I say, who did they really include? Now, some kudos, you can probably tell from the formatting for those of you who read papers that this is a New England Journal of Medicine paper. So our sort of medical gold standard as far as publications. I will give credit to this publication, which is that at least they have collected race, ethnicity, have collected income. There are many papers where that isn't even collected. And so this is the diabetes technology arm, and this is the sort of control arm. And what you can, the other thing I'll tell you is this is a national study, so it's not just a single site. And what you can see is that they did not recruit anyone who identified as Black. They recruited 1 individual who identified as Asian in the closed loop arm and 4 in the control arm. Sorry, 1 in the control arm. And then they only recruited about 8 people in total who identified as Hispanic when you look at the overall amount. The other component is that we didn't talk about is parental education level. So if you look here, nearly everyone has a bachelor's degree or more, which is a very specific demographic, right? Not everyone in America has necessarily has a bachelor's degree or more. And then again, this is shown by the annual income. The last arrow here is for that 90% have private insurance. There's a reason why this is relevant, and it's because when we design clinical trials and when we recruit for clinical trials and we generate data that disproportionately represents individuals who hold historical privilege, then the data and the findings are not always applicable to everybody else, 1. And 2, when public payers see studies like this and they see 90% are privately insured, now that doesn't mean don't collect the data and just don't tell anyone. It means recruit equitably. But when they see this, they say, well, this is not the population that we're serving. And we know that our population has generally more adverse outcomes, which is usually the cause of that is placed on the community, but it's really these structural factors that we're going to be talking about. So why don't you show us that it works in this minoritized population? And if that question ever comes up to anyone, an efficacious intervention that you need to prove works in a minoritized community, I would encourage people to kind of push back on that, right? If there's not a biological reason for there to be a difference in the functioning, then I don't know that I really need to prove it. But what does happen is one-off pilots are sometimes generated to prove that it is efficacious in the group that you're looking for. So sensors are part of the diabetes technology. And this is an older trial. This is 2013. But the last decade of California policy approximately has cited this paper as to why they've picked the bureaucratic needs that they have. So this was a pilot in a low income, actually from my alma mater. I didn't know this study was happening, which is an under-resourced county hospital who deliver excellent clinical care, but not the infrastructure to do research. And they recruited 25 low SES, primarily Latinx youth with minimal prior education and sort of minimal support in using this new advanced technology. And I'll cut to the chase, which is that the study conclusions were that the kids loved it. They found it really helpful. It made their life easier, but they didn't see an improvement in hemoglobin A1C. And so the conclusion generally from the literature and from the sort of the research community and the insurance payers was that even though we know that this technology works well, it seems to, for whatever reason, not work well in low SES youth. So what ended up happening was there was a ton of policy that was put in place to make sure that those kids who had shown commitment to their diabetes management by a certain number of pricks, checks per day, those kids who had a commitment to wearing a CGM, those kids who were considered sort of more committed or more likely to succeed were the only ones who were given it, which meant there was a ton of bureaucratic paperwork on our end. And the result of that policy is that there were a lot of interruptions to people who had public insurance in getting their CGM use. And what we did at Stanford was we just looked at all of our kids with public insurance and we said, let me just see, why is it that the CGM doesn't seem to be working quite as well or quite as reliably? And we took a difference of the glucose values before they started their technology to right after they started it. And then we categorized every single visit they had and said, if you didn't have any interruptions, how did you do? And if you did have interruptions, how did you do? And I will, again, spare people some of the methodology, but happy to talk about it afterwards because I get very excited about this. But what you see is that the way that it's not just the technology, it's the way the technology is delivered or way the intervention is delivered to individuals that ends up impacting whether they actually benefit or not. And the reason we hypothesize that the reason that you saw a null effect, a sort of lack of change in hemoglobin A1C, is if you took this whole cohort and you just collapsed them all together and you didn't allow them to be individuals or heterogeneous like they really were, you might get an average that says, oh, they didn't benefit from their hemoglobin A1C. So I took you from essentially the initial landmark studies through to policy, through to what the clinical implications are. And it really took this study and a few others to really get California's policies to walk back. So I've taken you all the way through policy. So these are all the reasons why equitable research matters, because it plugs in all of those. And for my basic scientist friends listening here, there, and everywhere, you're not off the hook either. Because this is probably the thing that has been revolutionizing CF care. So CFTR modulators have really modified and altered how an individual with CF is going to live their life. And what happened, as you can see here, by race ethnicity, how many people have unclassified mutations, which means if you don't have a classified mutation, they can't study how to fix it. And then what happened was some of the early basic science around CF and CF genetics really focused on specific mutations that for one reason or another tended to be more common in non-Hispanic white individuals. And now there's this revolutionary treatment that's supposed to really modify the disease course. And sorry if I'm walking off screen, but you can see here that the percent eligibility is the greatest in individuals who are non-Hispanic white. So this is why, as basic scientists as well, it really matters, not to mention some of the existing cases like Henrietta Lacks that really talk about why it's so important that we're all responsible and equitable in our research. So I focused a lot on the researchers, and many people who've been doing clinical research will say, I hear you, Ananta, but there's also a difference in the actual participants themselves. And so I wanted to take a moment. There's not a lot of data, although it's starting to emerge on willingness and interest to participate. I'm actually going to skip. I left these in there for when the slides go out or so you have access. But This is actually a fairly old, again, meta-analysis. I haven't seen another one come out, but I like it. It was published by George et al. In the American Journal of Public Health, and now almost 10 years ago. And what they have is they have all of the various, and they don't just focus on one race ethnicity, but they tried to catch all the individuals who hold a different race ethnicity and where they grouped it together. So for example, mistrust is something we often hear. And they tried to really kind of parse out and nuance, what does mistrust mean in different communities? So for example, in this meta-analysis, they said Black and African-American families, they tended to say that they thought that white individuals would benefit more from institutional research, whereas mistrust looked a little bit different in the Latino families, where they said that maybe there's more medical experimentation. And so understanding, again, this comes back to the privilege of individuality, understanding who the participant sitting in front of you is, and not just saying, oh, they're a person of color, so they're probably going to be hesitant, but trying to really understand where that hesitation might come, and then kind of owning it on our end. The other thing that's not often well appreciated is the things that encourage, right? We talk a lot about barriers and things that don't work, but there are certain things that really encourage participation in clinical trials. And that is cultural congruency, and it's, the benefits of participation. And altruism is something that I anecdotally don't hear acknowledged as much for communities of color and minoritized communities. They want to do, there's an interest in contributing to the greater good as much as there is anywhere else. So hopefully I've set the stage for kind of the state of disparities, some of the structural drivers. And what I will focus on is really some kind of coming back to that onion, right? At the level of the individual and your research team. For those people who are here, what can you do? And then I'll hand it off so that, we can really hear what the institution has set up. And so if you're, as a researcher or as somebody who's participating in clinical research, I think the very first thing is at least examine your own biases. And you don't need to go, you can. I shout it from the rooftops if you'd like to, but at minimum, be honest with yourself, right? Because then if you're at least honest with yourself about where your intended and unintended biases are, then you can at least start saying, hey, that's a blind spot I got to be aware of. And there's varying levels of comfort of what people are or are not willing to do. And I find joke that I have my reading capacity is at that of a third grader or exclusively medical literature. So this book, so you want to talk about race, is actually very easy to read. So coming from somebody who doesn't read many books. The second is this commitment to dig deeper to the data. And there are lots of examples that I can state, but I think oftentimes the prior example I gave about taking a really heterogeneous group and collapsing it and then saying there's no effect is an example of a commitment to dig deeper into the data. To engage communities, we have really great publications out that talk about how engaging with community health centers really goes far, and that's one of the tenets of MCHRI. And I'm just going to highlight how hiring, but specifically engaging diverse clinical research staff is really, really big. So this was a study that was funded by the MCHRI Structural Racism Pilot. And what we did was, so the primary minoritized group that I was working with are the Latinx community in our area. And so I hired a bilingual, bicultural Latino research coordinator who then didn't just do the recruitment, but also built all of the protocols as we went along, modified how we discuss things. And I just want to kind of say it was really exciting because we exceeded our recruitment goals. We had a very, very diverse cohort. And I presented this in one of the other ones, and we had really excellent kind of study completion rates. So I'll just close with, before I hand it off, with just this last pin as you think about where these results really should go. So many of us who do clinical research, we have findings, and we always think about the next abstract we're going to submit, the next paper we're going to submit. But I encourage everyone to also make this pin. How are you getting it to the community? Have you gotten your results back to your participants? That's actually really critical, a simple infographic, because many, many, many minoritized community members that I talk to say, I don't know what you're doing with my results. You poked my kid, and then I don't hear anything. And then the other thing is getting it out on blogs, like Scope is a Stanford blog. And then I put social media platforms. I think that Bird is now an X, or, you know, you get the idea. Instagram, like get your results out there and engage with communities. And the second is policymakers. They're the other people who do not have access to your data. So if you're saying this thing works and this thing works well, and I'm pumped about it, and that's why I write grant after grant, then let your policymakers know. And there's there's a lot of infrastructural support to do that. And then the researchers, right? Like we're gonna do that part anyways, because of the institution we're in. So I'm gonna pause there. The next slides are around how do you make sure that you deliver your message well to the audience. So I'm gonna leave that pinned along with this, just kind of shout out to this. It's actually a cancer resource center, but it's about how do you present data in a way that's applicable to various audiences. So I just wanna call that out. And I will hand it off to you, Maya. Come on over for institutional resources. Hope this works.
Okay. Hi, I'm Maya. My official title, as has been said, is the CTSA Hub Liaison Manager for the Trial Innovation Network, among other things. I'm also performing several other roles at Spectrum, and one of them is supporting the Research Participant Engagement Program, or RPEP, as we like to call it, because it's way too long, which is what I'll be talking about mostly today. And I will also introduce other central resources that we have here at Spectrum and the school. Our program was created to try and address one of the greatest challenges of clinical research, not having enough participants. And then we were also looking for ways to specifically address the lack of diversity within research. It takes a village. Catherine Connors, who is the creator, the brain, and the heart of this program. We have Andrea, who's our program coordinator and our bilingual Spanish specialist. And then we have a really, from the start, strong collaboration and relationship with technology and digital solutions. And I'm sure you all know Cjo and Trisha from Children's Research Informatics. We couldn't exist without that collaboration. And we do have faculty advisors who are currently Aruna Subramanian and Anisha Patel. Our services are mainly can be mainly divided into three areas. The first one is consultations that we provide to study teams about recruitment. The second one is actual outreach that we do through our platform that was developed here. And those would be direct email, outreach through Children's Epic, MyChart messages, postal mail, and we have now started, well, almost a year now, adult Epic, My Health messages for some studies, hoping to have it available for all studies in the very near future. And then our outreach beyond Stanford, that has nothing to do with the Stanford electronic health record connection. We are hosting the Stanford Research Registry, that is a REDCap database of individuals, mostly from the Bay Area, who have just volunteered to be contacted for research. An additional, we have some connections to social media, and we have some tabling events and community we have some tables in community events. Part of the consultations will include, as appropriate, connections to other resources that are at Stanford, including the Office of Community Engagement and the Trial Innovation Network that I will get to a little later. Special for the Children's Epic, there are two additional features that may be applicable to your studies and available to you. We call them the Cjo specials because he is the one who developed them. They're best practice alerts where pop-up can appear to specific providers or specific clinic where during a patient visit when they meet certain eligibility criteria, and the provider can at that time, just say, hey, you may be eligible for the study. Would you like to learn more? And then immediately share a MyChart message with them or a barcode, and that's that. The other one is bulk MyChart study invitations, where they are sent from a clinic to all their eligible or potentially eligible patients at once. Of course, here we would have to have endorsement, documented endorsement by the clinic that they allow this outreach to happen. Now you notice me talking about provider, clinic, and endorsement, and that is because, as you know, study teams cannot cold contact potential participants. We have our IRB recruitment guidance that explains this. And of course, we have individuals have to have this, how was I contacted? How did you learn about me? And the explanation of, I have a waiver for recruitment, I looked in STAR, this is how I got your name, is not acceptable. So yes, you have to have this provider referral at least. Talking about STAR, and I'm not sure if all of you have used STAR or know about STAR, so I really wanted to talk about this a little bit. This is our approved resource for working with clinical data for research purposes. It pulls EHR data daily from both hospitals and ancillary clinics. And it has two major tools. One is the cohort discovery, where pretty much anyone with a SUNET and what's it called, cardinal key, full traffic, whatever setup, can go in there and look at de-identified patient counts based on eligibility criteria. And that would include demographic distribution for that cohort, and see if their study is even feasible, if what they want to do is even feasible. The second one is chart review, and that would require privacy and IRB approval that is study specific. And then they can go and pull that PHI of that cohort that they've identified. So the study team has all of this information, but they can only reach out to their own patients, to the patients where this provider relationship or provider to investigator relationship, or clinic, some type of clinic referral. And this is where we come in, and where this program really comes in as honest broker. Honest broker is really a trusted third party where we conduct the research on the study team's behalf. And you, the study team, will only learn about the individuals who are interested to participate. If they're not interested, if they didn't respond, or if they requested to not be contacted ever again, you will not hear about them. And this is, with this mechanism, we can reach out to everyone that we identify through STAR that is a Stanford patient. So this is the outreach that we do, sorry, I just forgot. The outreach that we do is through a platform that we developed specifically for that. And this platform allows access to data and it's really a tool that allows scalable outreach in both the number of studies that we can outreach to at once, and for studies, the size of cohorts. So it can reach out to thousands of individuals at once. Our platform works in a way that the study team creates the cohort in STAR. We then, the RPEP team, pull the chart review and upload it into the platform, which is also called PEP, not RPEP. Sorry that it's the same letters. We pull it into PEP. And now in order for PEP to work, the study has to be registered in ENCORE because that's what it talks to. And it has to be per participant accrual, so it can know what's happening. So we pull it into the platform, and based on what outreach method is applicable to your study, for example, direct email is not relevant to studies that don't have healthy controls, of course, because of PHI. So based on what outreach method is applicable to your study, PEP will decide which is the best way to outreach to your study and automatically send it that way. It's amazing, right? And we are the ones who are sending it. It's on your behalf. We have very strict procedures that have been reviewed by all stakeholders. We have templates with language that explains to them why they're being contacted and how they're being contacted. And again, every stakeholder you can think of has reviewed and approved that language. So has all been vetted and tested. We can also track age, race, and sex metrics. For that, we need the data that's in Encore, and Encore pulls it from whatever is in EPIC. That's how the flow of information works. Now, I'm sure most of you or all of you know about the We Ask Because We Care initiative. And EPIC is now collecting more precise demographic questions for race, ethnicity, preferred language, sexual orientation and gender identity, disability status, and accommodation needs. And we do hope that once this data becomes more robust, we can rely on this one to have more information to support more granular tracking to support our platform for more granular distribution for recruitment as well. A new feature that just came out in our platform at the end of June is the demographic optimization, and we're very, very proud of it. It was designed to help diversify our populations, and study teams can decide on target percentages for race, ethnicity, and sex at this time only, just for these 3 categories. And we can enter it into our platform. And then when PEP prepares the outreach, it will target the outreach based on those target percentages. And it will prioritize based on the percentages that we entered. And then with each wave, it will recalibrate based on what we now have enrolled. And that's how it goes. Those are the 3 categories that we have, and they're based on how EPIC has historically collected information. We are looking to add additional categories such as age ranges, pregnancy status, disabilities, SOGI, and the more comprehensive racial breakdown that is being collected in EPIC now once it becomes more robust. And study teams can decide if they want to use it or they don't want to use it. It's up to them. There's just a click of a button. This is how it looks like in our platform. The benchmark column is that's from the 2010 census for the Bay Area. And the target population is where the study team can decide what goes in there. The default is for the benchmark, but the study team can just decide what goes in there. Of course, you want to be realistic. You can't decide that. You have to be realistic with what the population in the Bay Area actually is, or the population in Stanford actually is. So we highly recommend when you're doing your cohort search, press that analysis button to see what the distribution actually is and base your percentages on that. Otherwise, it's just, you're never going to get there, of course. And then, like I said, because if you keep updating your accrual in Encore, PEP will know who you've already enrolled, and based on that, it will change. It will collect the accrual, the actual recruited, and change the preferences and change who now needs to be recruited more, which group now needs to be recruited more. So we've just started this. We don't have any data on how this works. We'll probably need months and months, if not more, to know how this works, but we are very, very excited about this. Now, obviously, we want the census data from 2020. It was just collected a little differently than how it's collected in EPIC, and it's right now available only in a county by county format. So we are working on how to get it into PEP. It's coming. It's just, we're just sorting this out. Still, from what I saw, the major change is more Asians. Really, just like that's the only one that is really what's the word? Apparent, easily apparent. So all of those outreach that are done through PEP are for Stanford patients that are identified through STAR. If you want to reach out to individuals who are Bay Area in general or not at all Bay Area, we have the research registry, and there is, of course, the social media aspect of it. So as I said, the research registry, it was created during COVID specifically for COVID studies, most specifically for the children's COVID vaccine trials, which was very popular. So it grew very quickly during that time, but it keeps growing still. We present on it and tabling events, and people sign up for it. People still volunteer for it. I think the ratio, I'm not sure when that data is from, but the ratio that I have here is 40% are under 18. And individuals have the opportunity to respond to questions about health questions, habits, demographics, and they don't have to answer to all of those questions, but they can. So based on that, we can filter and create a little cohort, and then we can email them and invite them to studies as well. We also have a collaboration with Study Pages. Study Pages is a platform that has a landing page for each study online. They've created, what you see here is our Stanford directory. Each study will have its own, once you click it will have its own landing page, and you can connect it to a pre-screening survey. And there's a participant management dashboard. You have HIPAA compliant text messaging and other participant management tools. It allows for multilingual templates, so individuals can select which language they want to see it in. Of course, if the study team provides the additional language. So just wanted to make you aware that we also have this. We currently are in the final stages of a 100 studies pilot that the Office of the Senior Associate Dean of Research and the CTSA grant is funding. I'm not sure how the following funding structure will look like, but we would definitely still continue with this collaboration in some way. And they've been really great partners for us. This is here as a teaser for part 2 of this workshop that is coming when? Sorry. Next Wednesday? Yeah. So this is just a teaser and a resource, but while you await that presentation. The Office of Community Engagement can provide additional resources for while you design your study and after, but ideally before and while you design. And there are the contacts here. The Office of Community Engagement also created this table about how to engage with underrepresented minorities. Please consider using this table for discussions with your study leadership to see if there are ways to address these barriers. This is just here for you as a resource. One of the things that are we good with time? Ooh, shoot. Okay, so one of the things that I just wanted to talk about quickly is language. Language is, of course, a barrier. So I just wanted to make you aware that about translation and interpreter services. We've seen that some are not aware of what is going on at the hospital. So the CRSO webpage, if you scroll all the way down, you will see language support for maternal and child health research. And then the resource and guidance link will take you to a little slide deck with all the information that you will need for your maternal and child health studies. The Spectrum resource webpage also has information for translation services for both the adult and the children's hospital. Just a quick, I have to say it. FDA has just come up with a new guidance for informed consent, and where they say that their expectation is that even if one person was signed on a short-form consent, they would later on need to receive a fully translated consent in their own language. Now it's a guidance. I don't want to scare everyone because no one has the infrastructure and the money for that right now. But just think about this. How important it is to have a fully translated consent in your own language and understand what is expected from you 3 months from now. Just putting it out there. It's a guidance. It's non-binding. It's just, but it's trickling from the top down now. So this is great. Just as an aside. Our RPEP, as you've seen, is collaborating with Encore, with the clinical research units initiatives, and with the Trial Innovation Network. It is a national network within the CTSA program that provides support for multi-site clinical research, and multi-site is 3 or more sites. It's expert guidance from the study design until the end of study. It provides access to the entire network of CTSA funding, CTSA award supported academic institutions. And it will provide, of course, access to larger and more diverse population because it's across the entire country. It offers investigators consultations and resources for those 3 or more sites in study planning, community engagement studios, what else did I want to call out? EHR-based cohort assessment, where they can come out with a cohort query that we can just send to all of those institutions and ask, can you run this query, please? And let us know what you have. And based on that, we can just invite them to participate in a study. And they write you letters of support for your grant. So you can budget for that as well. If you want to learn more about it, I'm the contact person. Please contact me. Our program is expanding to include more tools. So there is some cost now associated with some of the services. It's all on our website. Please include budget, include recruitment in your budget. It's usually underestimated, if estimated at all. And it's really, really, really important. Think about if you are recruiting special populations, think about adding more staff or more staff time with specific skill sets as needed. Really important. Think about screen failure rate. as you're thinking on your project. These are just metrics. This is it. Sorry, I took too long. That's it. Oh.
Terrific. So we have about 5 minutes. So for those that are watching online, please, I'm watching the chat here. I can read off a question, but let's start off in the room. The bonus of being in the room, you guys get the first questions. Any questions for our two speakers? Yes, Chris.
My name is Chris Russell. I'm a new faculty member. Oh, sorry. My name is Chris Russell. I'm a new faculty member in the Department of Pediatrics and NIH funded. And so I've heard some rumors that in the hospital, like we're thinking about recruiting diverse populations, but access to interpreter services and in particular in-person interpreters are not, it's not equitably allowed. And so I'm just wondering, how do we, when we're talking about trying to recruit diverse populations, how do we reconcile that desire to make sure that everyone's getting the same level of engagement with not having necessarily access to those resources for people who speak languages other than English? And I don't expect a full answer. I'm just curious how you might approach that.
So access to, as far as I'm aware, access to interpreter services is allowed, but it's very limited because of the number of interpreters that are there. Priority is given to clinical care always. And I know Alison Falwell and her group are working to allow more interpreters from the study team to support this. But yeah.
I'll just add that the other piece is, I think I've done a lot of back and forth with various members around this question specifically because I think our diabetes care teams specifically, and there's actually 2 iPad interpreter services that are approved. So Seracom, which is iPad, which has its own limitations, but it's at least allows you to, so I think Seracom and one other that we can kind of send out if anyone wants to know, but generally the iPads that are used and are available technically should be allowed for interpreter services because there's the correct business agreement between the IRB and the, but so as long as it says, I know Seracom for sure, but I think there's 2 of them. There's one more. So it would be the iPad interpreters in place well. And then yeah, as Maya said, there has been leadership work to try to make sure that it is not just through an interpreter iPad, but also there in person.
Any other questions in the room? Yes.
Maya, I noticed in your slides that one of the features to your service through Honest Broker was texting. That's something that is not currently being used or not allowed, but how is that implemented in your program?
So texting through our platform is not yet available. We're hoping to make it available sometime in 2024, which is why I didn't say anything about it. We are still working with technology and digital solutions to identify how this is going to work. If you're working with study pages through their platform, there is texting for participants.
Okay. Good to know. Thank you.
On the study pages, I would imagine it leads you through who to contact, who to, sorry. On the study pages document that you showed, it does lead you through who to contact in order to get your study published on that page.
Absolutely.
Okay,
Yes.
great.
Well, I'm monitoring the time, so I want to wrap up and just thank our speakers again for setting the stage of why this work is so important, and then Maya for sharing so many incredible resources. Some of those I learned today for the first time, like some of the EPIC pop-ups and the other tools coming from the spectrum. Amazing. So I'm optimistic for the future here, and I really thank everyone for engaging in this important conversation. So thank you.